speaking, we have Dr. Alex Hoang. He is a dual-trained neurosurgeon in endovascular and open vascular neurosurgery. Dr. Hoang is a Texas transplant after completing his endovascular neurosurgery fellowship at Baylor College of Medicine here in Houston, Texas. Before coming to Houston, he received his Doctor of Medicine from the University of Utah and completed neurosurgery residency training at The Ohio State University in Columbus, Ohio. Dr. Hoang specializes in cerebrovascular endovascular neurosurgery.
And also one comment, you always when you hire a new faculty member, you never know what you get if you never train them. But Alex has been a really pleasant surprise.
Thank you, Dr. Fritz. Thank you, Dr. Volpe and Dr. Gard for inviting me for this talk. I was tasked to talk about medium vessel occlusions and expanding kind of the thrombectomy indications for medium vessel occlusions. So I have no disclosures. There have been several randomized controlled trials that have shown an overwhelming benefit of endovascular treatment for large vessel occlusions. And this has kind of changed our treatment paradigm for large vessel occlusion strokes. What does that have to do with medium vessel occlusions? And the overwhelming benefit suggests that there may be some benefit in these patients with medium vessel occlusions. And it's important to why is this important is that a lot of the unintended events of intravenous TPA and endovascular treatment causes thrombus fragmentation, leading to distal emboli in the distal arteries. And for us to give patients maximum benefits from treatment of LVOs, we need better effective rescue endovascular therapies for these medium vessel occlusions that we iatrogenically get from TPA as well as endovascular treatment. And it's challenging to define what is a medium vessel occlusion. Conceptually, there are two different types. First is a primary MeVO, so a person that comes in with an M3 or an M2 occlusion. And then there's a secondary MeVO, which can result from iatrogenic thrombus fragmentation during endovascular treatment, as well as a consequence of clot migration, especially after TPA. Three features kind of define that gives us a reference point for medium vessel occlusions. And the first two are anatomic, kind of vessel anatomy and vessel size. But there are a lot of different inter-individual variability in vessel anatomy and vessel size. So another reference point is the clinical deficits. What is the NIH stroke scale score for the patient? And there's also some impracticalities with clinical deficits, being that some patients have increased collateral supply. So really a reference point is a combination between anatomy and the patient's clinical deficits when we define a medium vessel occlusion. Anatomically, a medium vessel occlusion includes codominant or non-dominant M2s and M3s, as well as A2s and A3s and P2s and P3s. And depending on where the thrombus is, in patients in eloquent territories, it could lead to a profound clinical deficit in what we see in the patient's NIH stroke scale. In contrast to large vessel occlusions, for which endovascular treatment is the standard of care, the role for endovascular therapies for medium vessel occlusions is really unproven. Only one study, Mr. Clean, only Mr. Clean had included patients that had an isolated M2 occlusion, and of that, only 8% of the patients enrolled in that study had an isolated M2 occlusion. And a lot of the other studies, including Escape, Swift Prime, Revascat, excluded patients with M2 occlusion. So, there is a lack of randomized controlled trials for medium vessel occlusions in terms of endovascular treatment. We always think of, before this, I always thought that medium vessel occlusions were uncommon, and usually these patients had a good natural history, but really these are very common and could be very debilitating, and these patients have poor natural history. When we think about all the intracranial occlusions, patients that present with large vessel occlusions 25 to 35% of the time. And for these medium vessel occlusions, these are equal to large vessel occlusions. So the same number of patients present with medium vessel occlusions as they do present with large occlusions. So this is a large patient population that are currently underserved. So what is the natural history? Are MeVOs less severe? And so these two papers kind of show kind of the clinical course as well as natural history of patients that have medium vessel occlusions and treated medically with TPA or without TPA. And we commonly assume that these deficits are less severe and that the outcomes are much better than large vessel occlusions, but really this is a false assumption. Even though MeVOs lead to a smaller core infarct, the occlusion of an eloquent area can still result in severe neurological deficits and could significantly impact their quality of life. So, these patients, when they present with a MeVO occlusion, the baseline NIH stroke scale of the entire sample, they have a medium baseline NIH stroke scale of 7 with an interquartile range of 5 to 12. But when you look at it, 25% of these patients have a NIH stroke scale greater than 12, and 70% of these patients have an NIH greater than 6. So, these presenting NIH stroke scale scores are still rather high for patients that have medium vessel occlusion. When we look at the outcomes, these are the clinical outcomes of these patients with medium vessel occlusions, and only 50% actually have an excellent outcome. And when you exclude the proximal M2s as well as patients with a high NIH stroke scale greater than 2, still, it's about 45% of these patients do poorly or are disabled or are dead within 90 days. This is another look at the graph, basically broken down to whichever vessel is occluded, and we still see poor outcomes. 38% to 56% of the patients are disabled or dead at 90 days in patients that present with a medium vessel occlusion. When we look at the influence of TPA and recannulation in these patients, we see that TPA does shift the MRS scale, and there's improvement in the ordinal MRS at 90 days. And really what we see that these patients have the most benefit from is recannulation. If you could recannulize these patients with TPA, they do very well. And within this cohort, early recannulation was only seen in about 47% of patients with TPA. So, there are about 50% of patients that don't recannulize, and those are the ones that do poorly. So, kind of overall, 50% of patients, only 50% of patients with MeVOs have a good, excellent functional recovery. So the other half, is 50. The other 50% is quite a large number. And medical thrombolysis with IV TPA is suboptimal, and IV TPA does improve ordinal MRS, but it's not associated with excellent outcomes. And the only thing that's associated with excellent outcomes is recannulation. So where are we with endovascular treatments for medium vessel occlusion? So currently there are no published randomized controlled trials, and the only level 1A evidence is for large vessel occlusion. But really in clinical practice, clinical practice always precedes clinical guidelines, and if you ask any neurointerventionalists, if there's an M2 occlusion on the left side, I think there's enough evidence out there to treat those. Here's an example of a left-sided M3 in the superior branch of the affecting speech, and we were able to go up there and aspirate the clot. So there is evidence out there, And this is a systematic review of 2,000 patients showing that mechanical thrombectomy can be safe and effective. And it kind of splits it up between aspiration, stent retriever, or both. And basically, it's effective, but there is a risk of hemorrhage, subarachnoid hemorrhage, and symptomatic ICH with mechanical thrombectomy. So here's just a quick case example: patient presenting with a stroke, M1 occlusion. We see here a distal M3 occlusion. Should we go after it? Should we stop? In this case, I put a catheter into that M3 branch, aspirated, and we were able to get a TQ3 revascularization, with leading to a small stroke. But given the poor natural history of distal vessel strokes, and the increasing evidence of safety and efficacy of mechanical thrombectomy, further randomized controlled trials are warranted. But there is less to gain and more to lose with medium vessel occlusions. And the challenges are technology, training, and outcome assessments that play a major implication in trial design and execution. The current barriers are technological barriers are two. One is the lack of appropriate devices. The devices that we have now are relatively oversized, which causes an increased risk of iatrogenic complications. So, there needs to be a development of smaller devices that optimizes access to these distal vessels. The second is detection of MeVOs. It's easier to detect a large vessel occlusion, but with advent of multi-phase CTA, CT perfusion, as well as AI, we're able to detect these medium vessel occlusions better. And there's new expanding devices that are coming out to the market that address this. And so over here, there's a stent retriever that is suited for vessels 0.5 to 1 millimeters in size. So the technology is coming. And then, there's a lack of expertise. So, a thrombectomy capable stroke center is important in treating MeVOs in the future. And currently there are a couple of trials ongoing, and I just wanted to highlight some of them. There's no data out yet, but there are 4 trials: the distals trials, Escape MeVO, Discount, and Revisor trials that are ongoing that kind of address this matter. So there should be some exciting new data coming out soon. And that's it.